Hi and welcome to this, our fourth in our series of videos for frontline family violence workers and therapists. This is a collaboration between several agencies and individuals, and all the details can be found on the Centre for Excellence in Child and Family Welfare website. We'll be giving you a link to all the information and resources at the end of this video. First, we would like to acknowledge the traditional owners of country throughout Australia and recognise their continuing connection to lands, waters and communities. We would like to pay our respects to Aboriginal and Torres Strait Islander cultures and to elders, both past and present. Now, anyone who's seen the previous videos will know that some of our country's top experts have given up their time to be here, and today is no exception. We've got 4 new members, which is pretty exciting. So I'm going to start by asking each of them to introduce themselves. So first we have Sue Hermans. Welcome, Sue.
Thank you, Nick. Hello, everyone. I'm Sue Hermans, and I work for Berry Street Take 2 up in Mildura, which is the far northwest of Victoria. So up here, Take 2 delivers many programs, but most recently we've started delivering Restoring Childhood, which is a response to family violence and working closely with young people who have been affected by violence. So I've been working with Take 2 now, started 10 years ago. And 2 years ago, I popped across to the Department of Human Services to Child Protection and worked as the principal practitioner for 2 years, and then have popped back to Take 2. So it's lovely to be back at Take 2. So I have a background in psychology, developmental disability. I have a master's in social work, and I'm working on family and systemic therapy masters at the moment. Hopefully before I retire, I'll get that out and done. So it's lovely to be here today.
Wonderful to have you, Sue, and that sounds far too busy, but congratulations. Debbie Park, welcome, Debbie.
Hi, Nick. Hi, everyone. So I'm Debbie Park. I'm a maternal and child health nurse here in Colac, and I've been working here now for about 7 years. I was a midwife at the Colac Hospital prior to that, so I've got a lot of history here in the town. I do universal and enhanced maternal and child health, and we provide a fantastic service to the Colac Otway Shire, which covers about 3,500 square kilometres. So it is quite a broad area that we cover. Some of our workers travel an hour or so to get to work. But we support all our mothers and babies up until they're 3.5 years of age, the children, and we just support the parents in their roles. We do 10 main visits to do developmental checks on our mothers and babies from newborn to, 3.5. So we have great contact with the services in around the Colac area. So we like to provide that nice collaborative care to our mothers and families.
Well, you don't get much more frontline than the maternal and child health nurses. No. So wonderful to have you here, Debbie. Yes. Vivek Rekar, welcome.
Thanks, Nick. Hello, everyone. I'm Vibhai Rekar. I'm a child and adolescent psychiatrist based in Shepparton. I've been here for the last 9 years, and I work in the Goulburn Valley Child and Adolescent Mental Health Service as a child psychiatrist. I'm also a 0 to 3 fellow. So 0 to 3 is an organization based in the US that has done a lot of work working with infants and toddlers over the years. And my particular area of interest is working with preschool children under the age of 6. We are also involved in a research project called Recover, that's reconnecting mothers and children after violence. And so we are one of the sites, project sites for delivering child-parent psychotherapy. And I'm really interested in working collaboratively with other agencies so that we can do the best for the children and families that live in our region.
Thank you, Vibhay, and wonderful to have you on board. And Karen Glennon, welcome.
Thank you. So I'm Karen Glennon, and I'm in a regional networking position covering the Barwon and Wimmera Southwest regions of Southwest Victoria. And it's working across all of the homelessness and family violence agencies within that area. So my role is very much around supporting agencies to think about how they work with children and respond to children across homelessness and family violence.
Well, wonderful to have you all on board as well, Karen, and thank you all four for coming along today. This whole project came about because of a recognition of the difficulties faced in this time of COVID for anyone who works with family violence. Now, people who've seen our previous videos will know they focused on working with families and children, responding to your questions. And in our third and most recent, we had a particular look at Indigenous issues. Now, today's video is devoted, as you might have guessed from the panel, to rural and remote communities and the people who work with these families. So I want to start with our first question for our panelists. Karen, I'm going to start with you with this one, if I may. What do you think are the specific challenges that rural and remote communities face in this time of COVID?
I think what we have to really understand is that rural communities have faced a lot of adversity in the last number of years. And while we can be very resilient and proud and very proud of our communities, we've had a lot of external things that have impacted quite significantly on our communities. We've had major droughts, floods, fires, inconsistent incomes for families, price fluctuations in goods and services, a lot of industry downturn, business closures, and high suicide rates. And when you think about all of those things in small communities, they impact profoundly because communities are so connected and we know lots of people within our communities. So then you added COVID-19 on top of all of that, and many of these families in some parts of our state have just been through horrific bushfires and were struggling to deal with that and then got hit with COVID-19. So I think there are some of the things that outsiders might not understand about the impacts on rural areas that can profoundly affect.
And Debbie, from the maternal child health perspective, right there on the front line, what do you think the maternal and child health nurses are seeing that's different in this time of COVID, in these last 3 months?
As what Karen is saying, we've had a lot of challenges, mainly due to lack of employment now around the town. We've had a couple of services around the place that have now closing their doors, so that's going to be causing financial difficulties to some of our families. And that impacts them in many different ways, in the fact that we have limited services already available to our parents and we don't have the public transport that perhaps the metro areas have. So some of these families have to travel quite long distances to get to services, to get to paediatricians or to speech therapists or come in and see us. So it makes it very difficult, as in, just petrol money sometimes for some of the families to even get in here to see us. I think all of this increased stress is causing a lot more challenges for the family. They are very much more at risk now for mental health and family violence. There's a lot more stress in the families due to the fact that they are socially isolated and they are all in the one house all together, which is causing issues again with mental health and family violence for our little children.
Can I ask you with that one, Debbie, you say they're more at risk of, do your workers report seeing more incidents of violence? Are they seeing more that they're having to deal with?
We've actually had, it's probably not recorded as such yet, but we've had more conversations with our families about family violence. I had a particular family that came to me and said basically that being isolated has been major for them. Her trip to the supermarket was her time out, and her partner was continually ringing her the whole time when she was in the supermarket. And now in these times of COVID, that isolation was it had been normalised for everyone that she was isolated, but in actual fact it was very much an act of family violence against her and her children because he was very controlling. So it definitely has had an impact on our families. We've got families that live an hour away up on the ridge, you know, up in the Otways there, that are very isolated and basically don't get the assistance unless they put their hand up for help.
And Vibhay, from the child psychiatry perspective, what's your take on how things have changed in these last 3 months?
I agree with what Karen and Debbie have said earlier. So there's already a lot of stress for survivors of family violence, or people who are exposed to family violence, and then the additional stress has just been quite relentless, especially the consequences and the impact of the lockdown and the financial stresses. So we're beginning to see a huge need and demand for our services. During the lockdown, it was the referrals were less, but I think what we're witnessing now is a surge in the referrals coming through.
And what are those referrals for, Vibhay? What are we seeing are the practical consequences of these last 3 months?
So there have been like with children and young people having significant anxiety and depression, and especially those children with neurodevelopmental disorders like ADHD and autism, to be confined in a restricted space and to be having, that can increase the stress levels for families in itself. And so that has been really huge. And I think parents have struggled to cope with all that increased stress, in addition to all the other, you know, the stress that's there. So it's just compounded everything. And and we have our known clients who were seeing us before this lockdown, and they have had to adjust to the whole changes. And adjustment is really difficult for some of these children, and it's quite distressing. So especially children with autism. So it's been really hard for the families.
And Sue, can I ask you this? If we think about what the workers in the more rural and remote areas face, what are the issues from the workers' perspective that are more difficult in the more rural, remote communities compared to the more privileged and better resourced urban communities that I come from?
So I'm thinking that some of the things are quite similar in terms of our desire to connect with the families, to actually have that opportunity to be in the physical space with the kids and their carers. So that is been a challenge for everyone, I think, across the state. But particularly when you do have to travel a long way to see people. So, and I know we'll talk about it later, but that the idea of introducing telehealth into families that we may not have been able to reach before has been I suppose, a learning curve for us all. We've all had to make a bit more space in our minds to how we do that and how we send those messages of connection, that we're holding our vulnerable families and kids in mind, even though we're not physically with them. So I think the reciprocity, you know, of being physically with people has been a real challenge, because we know that it's incredibly important for people to feel noticed, you know, and that our presence is a present as such, you know. So that's been challenging. So particularly doing we call relational work with children and their survivor parent, you know, wanting to be in the space to help them feel safe together and do some reparation. So that's been tricky. Yeah.
And you mentioned, and we don't have to come to it later, because I think this is almost a crux of this kind of question, is that question about telehealth. You said we've all learned a lot over these last 3 months. What have we learned? What's working, what's not working? I want everyone to answer that question, but Sue, you mentioned this, so you go first.
Oh dear, yeah. You know, some of our families don't have the internet at home. You know, and some of our families will struggle to keep a phone available to them as well. And we're really mindful that that's another pathway of harm as well. If there's a person using violence in the house, they can restrict access to technology. And we're terribly mindful as well that the person who's using violence could potentially be in the house when we're connecting with people, either on the phone or over the internet. So there are extra things, I suppose, that are tricky. On a positive note, we've been working with a couple of adolescents who would much prefer this medium. They really would prefer us to hang out online with them and talk things through. So that's been a nice surprise. And I think our connection with our colleagues, so And I know that this is common across the board in rural areas, that we do have lots of other relationships with our colleagues in other agencies. There's a level of collaboration that is, really healthy in rural communities. And I think being able to connect with people, with colleagues over the internet has actually been really helpful. And I'm not sure about my the other people on the panel, but connecting to meetings that you normally wouldn't go to in the city has actually been really great, and giving people a feel for what that's like to be the person on the screen. Well, everyone's on the screen now, so that's been really interesting in terms of them having some empathy for what that might be like too.
Yeah, so there's some good bits as well, and you're absolutely right. I mean, I've certainly found this in urban practice. There are patients who are a long way away, and we can connect much more easily and more frequently by telehealth, and we have a good face-to-face. But let's focus a bit on that telehealth question, because it is, in a sense, one of the biggest changes that we've had in this time of COVID. Do others want to comment on what they found with the experience of doing this for the last 2 or 3 weeks? Some tips and tricks, things that was working well or things we should be avoiding?
I think one of the things that has been a bit of an issue, and I agree with Sue about those positives, because it has provided opportunities to engage with families and in ways that potentially suits them, but we do have to be mindful of, we have lots of mobile black spots in our area, and in isolated parts of the communities, many people have to stand nearly on one leg with their head pointing to the east to, get a mobile coverage. So that can be a really difficult thing. I think the other thing that probably has been a learning thing is that this suddenly started with no knowledge whatsoever. And so agencies had to run very quickly to find ways to do this engagement. And even learning what platforms are safe, what platforms provide confidentiality, what platforms are, people are able to engage with easily, has been a real learning curve. And I think to get some consistency across our systems will help that, because there are still some agencies using a particular platform that other agencies don't agree around. So that's going to be some work, I think, rolling forward that will need some discussion. And the other thing, sorry, I feel like I'm taking over here, but I think we need to really critically evaluate, what have been the major things. And we go to lots of meetings, and all of the time people talk about the fact that children are very invisible. And so how agencies have been able to engage with families and keep children on and in mind is really going to be, I think, something that may change the way a lot of agencies think about how they work with families and children in particular, if this becomes our new norm.
And that's a crucial question that we've addressed in previous videos, this question of how do you see the baby, both physically and metaphorically. Debbie, do you want to comment at all from the maternal and child health perspective about what that's meant for your frontline workers?
Yes. Seeing the baby, we talk about physically seeing that child. We've been doing a lot of phone consultations, and to be able to really listen to what the mother is saying about their child. But a lot of our developmental screens is observing that baby, is looking at how that child's attaching to the mother. Is the baby looking at the mum? Is the baby running around the room? And we don't see that over the phone. So that is difficult in a way, to try and monitor the baby's or the child's development. I've actually done a couple of developmental screens, brigance as we call them. I've done a couple of those over Zoom, which is very interesting, to see a little 3.5-year-old trying to point to things on Zoom and on the camera that they're not seeing. So it's a very different medium to what I'm used to doing, having children in the centre with us. To go forward from here, I hope that we are going to be able to see our children physically, but perhaps we won't. And I think we, as Karen says, we have to look at what mediums we can use, what platforms. Zoom's a fairly acceptable one in my workplace. It's a difficult one. We're not allowed to be using it all the time. So consequently, sometimes it's difficult to access Zoom at work. So that's why I'm at home. So it's very interesting how different workplaces will develop different platforms. I think in seeing the baby too, we're just making sure that our families are attaching well to their children, and we're trying to help them with that mental health for the children as well, which is Vibe's speciality there. But we're just trying to help our women to be able to make sure that they're caring for their babies physically and mentally when they're perhaps not as that well themselves, if they're suffering with isolation.
And so, Vibe, I might throw that one to you in that case. So in this situation where it's much harder to see people face to face, where we are doing more of this through telehealth and so on, how do we help those parents who are struggling?
I think Wendy Bunston in one of the, I think the first episode mentioned about this, but and I'd echo what was said in the previous videos is and a wise person, I think, has said that the eye sees what the mind knows, and if we keep the baby in mind, we can help the mum or the carer keep the baby in mind. And so I think bringing up the baby, the perspective of what's going on for the baby, let's think about the baby, and I think that's so important to not forget that, despite the distances, despite the mediums that are used, and to keep thinking and encourage the parent or the carer to keep thinking about that all the time. And this also reminds me of this concept of containment, and if the relationship with the carer is so important. If the carer feels contained and supported by the workers or the clinicians in the community, then that can help the carer look after the baby much better. So it's really important to ensure that the carer is held and feels contained. And that's been really useful in our setting to make sure that the parent is well supported. And similarly, the clinician or the worker needs to be well supported by their organization in providing whatever they need for them to do their work without having to go through a lot of hassles and effort. So I think it all ties in. The child surrounded by the family, surrounded by the services, and so everyone has a role in ensuring that each one is well supported to do this really complex and difficult work.
So I want to get really practical though. So you say we want to provide that support and care for people, but in practical terms, I guess I'm asking, what does that mean? One of my experiences has been that the good bit, if you like, about more telehealth is it's possible to provide more frequent interaction, even though it's not face-to-face. One of the experiences I've had is that people who are really vulnerable, I have a woman who I ring once a week who would normally come to visit me once every 2 or 3 weeks when she was able, but I can actually do this every week because it's much easier for her. Are there some specific examples you can give of how, and this is open to the whole panel, so Sue or anyone else, how are we actually in this time of COVID able to provide that extra care and support in a way that maybe we weren't doing before?
I can make a comment about the agencies working together. I think because of the accessibility has improved with the use of telehealth. We're not traveling to attend meetings. It's easy to set up meetings with colleagues, with child protection, and just keeping everyone in the loop as to how things are going. I think that's been much easier in our experience, and bringing colleagues together to develop that system that supports the family. So that's been really helpful. I'll open it to the other colleagues.
I think that sense of collective mind around the family, I love that idea. And you're right that we actually can do that because we can communicate more quickly and more effectively as well. And I think about that, how it replicates what we're trying to encourage within the diet, like within the relationship that the carer has with the child, in terms of the way that we as system providers are communicating. That's incredibly important, that we're actually modelling that level of, I suppose, again, like holding them in mind, so literally thinking carefully about what it's like to be this family, and sending those messages of empathy and of curiosity of what's going on, like being genuinely interested in what it's like to be in a relationship with this new baby and what's going on with the older kids. What do you think it's like for the older kids to be a big brother, and encouraging those kinds of conversations that bring out the internal world? So what do we think is going on, and thoughts and feelings, and helping each other, helping the families notice those things for each other by the kinds of questions that are asked. Yeah.
Sue, can I push you on this though? How are we doing that differently, or is there a change in the technique in the sort of COVID world? Because those principles don't just apply now, do they? But is there a difference about how we do? I want people to understand in a practical sense, how do we do this in this weird new environment that we're working in?
Yeah, and you're right. They're basic principles as such in terms of the work that we do. I think it needs to be, what I'm finding is we have more deliberate conversations possibly over the internet, where they feel a bit more purposeful, that you would be trying to elicit that information in a timely way without overwhelming the family. Because I know that we've got some colleagues who check in for 10 minutes 3 times a week, you know, instead of an hour, as you said before about the, I suppose, the short positive experiences that we know are a little bit like dosing, for want of a better word, of a positive outside experience of the safe other wondering about your family. So you can literally do that with phone calls or the telehealth more frequently, but for shorter time, so it's not overwhelming, I think.
I think that's a beautiful example of something that you're doing differently. I mean, you would never normally expect to see a family 3 times in a week for 10 minutes. But maybe by telehealth, that's something you can do and it's effective. Others, are there simple examples like that in a practical sense of what you're doing that's different now to what you were doing pre-COVID?
Sorry, Karen. I've actually found mums to be actually more open on the phone, perhaps a little bit more open to talk about or to disclose how they might be feeling, and a little bit happier to talk about the more difficult conversations, which is interesting in a way. Sometimes it's better to be talking face to face, but I've actually experienced that a couple of times, and that they're obviously more comfortable talking about more difficult conversations, which is great. And because getting on the telephone is a lot easier, I am doing a lot more phone consults to mums, as well as trying to back them up with some face-to-face consults as well. So there are definite benefits there, but of course, you know, there's nothing like seeing someone face-to-face.
It's an interesting example, though, isn't it? It's a little bit like talking to your teenagers when doing the washing up, so you don't actually have to look at each other. Sometimes it's a bit easier when you're not staring at each other face to face. Karen, sorry, you were going to say something.
No, I think I agree with all of the things that have been said, and I think some of the really practical things that I've heard from workers is that you know, they're taking around, using opportunities to potentially take around things like craft activities or things. And, you know, even if they've had to talk to families through the windows, just show them how to use activities and games or things. So some vulnerable families that haven't had lots of things, so they go around, show them how to engage with their children in a way that's safe for the worker and safe for them. They've done things like walk around the park, and so one might go one way and one go the other, and meet at various stages along the way. So they're trying to find ways too that are really clever in these times where they can't sit down in a room and chat. So it's what ways can we use the environment safely, keep our eyes on these families and keep them in our minds. And as Sue said, engage with them in a very curious way about what's going on for them in all of these challenges that they're facing. I think going back to that thing about workers engaging better, I spoke with some of the agencies, and at the start it was very much about workers were feeling overwhelmed with the level of risk that they were having to sit with and not quite knowing what to do. So they became much more engaged with ringing up another agency and consulting, rather than thinking, well, I can do this because I'll catch up with them next week, or I'll see them whenever and I'll do it then. So agencies have actually said in that respect, workers are thinking more broadly about their families too, and about how they can engage in a way using other professionals and using those secondary consultations to keep families in their minds, but specifically when there is huge concerns about infants and young children, that they're becoming much more immediate in how they engage with other agencies, rather than waiting for that larger sort of crisis, which I think can only be a positive for the families, rather than waiting for a huge crisis. We're managing things better along the way.
I think that's a really important point, Karen. And one of the things which in some of our conversations seems to have come up is that collaboration between agencies, particularly for people working in more rural and remote areas, always important, but maybe even more so in this particular time. Vibe, do you want to comment on that at all?
I agree with what's been said. I think it's so crucial because of the lack of the ability to have those face-to-face conversations. I think what we can do is to complement each other, the work that we do. Say, for example, in mental health, when we have communication with child protection, they find if we have been able to communicate with the family, and I think it just helps when the information flows very easily across the services, and it just helps the families get a better service eventually overall. So that's been one great change in my observation in the last 2 or 3 months, the ease of exchanging information. I don't know why we didn't think of this earlier.
Yeah, it feels like more satisfying work to be, it really does, like in terms of that, the higher level of communication, I think, as well, that you're actually, the more regular conversations, they have to be of greater benefit to the families.
Sorry, can you elaborate on that, Sue? What's the more satisfying element? What do you mean there?
I think the ability to turn to each other as well, like as professionals, to feel as though you can turn to each other and talk these difficult the difficult problems that are presenting with families. So it's a little bit like Karen said before, you know, really early on, everyone was terribly worried about not seeing the families as often or not being physically present. But when there's a few people doing shorter visits or having shorter contact, and then pooling that information and coming back together and talking about what we're noticing and what we're still concerned about, it feels much more like a collective, much more like a collective conversation about the family. And we've certainly had more contact with our child protection colleagues than ever, which is in a positive way in terms of coming together deliberately again on the screen, because you've sort of got to book it instead of ad hoc conversations. So we're getting together weekly to talk through difficult things, whereas that was a little bit more ad hoc before. It's really good.
I'm not hearing people missing a lot about what things used to be like, almost embracing the new normal as people keep talking about it and saying we quite like it. So I guess that's quite a nice positive note to come to an end with, because that is all that we have time for today. It's amazing how time whizzes by. Thank you for joining us. And please, people watching, please stay online to give any feedback and questions that you would like addressed in any future videos. And you'll also find a whole host of valuable resources available at this event page on the Centre for Excellence in Child and Family Welfare website. So that just leaves me to thank today our wonderful experts who've given up their time. Sue Hermans, thank you, Sue.
It was a pleasure, thank you.
Debbie Park.
Thank you.
Thanks, Debbie. Vibe Rekha.
Thank you.
And Karen Glennons.
Thank you.
Thank you for watching. I've been Dr. Nick, and we look forward to having your company next time.